Okay. Okay. Good evening, everyone, and welcome to the August meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter, along with Dr. Amy Cipolla and Dr. Jacob Wolf is our outreach chair. Normally, both Amy and Jacob would be with us, but they're not tonight because they are both currently sojourning in some remote locales without any internet access. So I'm going to be moderating and winging the tech stuff by myself with guidance probably. And let's just all hope that there's no glitches, because if anything happens that way, I'd probably not have any idea how to fix it. Okay, so for any of you who receive our chapter's monthly newsletter or otherwise have followed our activities, you know that this year we have been following an alternating schedule of speaker events with panel discussions. And the panels are on topics that are in some way related to the previous month's individual talk. And then every third month we do a networking event. So last month we heard from Dr. Gio Espinoza of NYU Langone Health, who is a renowned authority on integrative approaches to prostate cancer. And he presented on that topic to us on a talk that was called An Overview of What Works and What Doesn't in Prostate Cancer Management. And so for this month's panel, we decided, actually after some input from Dr. Rao and from Dr. Wolf, to focus on a practice-oriented topic rather than a clinical or research-oriented one. And I think it's fair to say that the vast majority of the webinars and conferences and other continuing ed events that we all attend or in some cases run are about research findings and clinical insights and treatment protocols and the like. And not that many, in my experience anyway, are focused on the ins and outs of practice itself. Maybe aside from the type that focuses on practice building techniques, but that's not at all the kind of thing we're focusing on tonight. So we thought it would be both really interesting and really productive and instructive to present a variety of perspectives on the practice of integrative oncology from a cross-section of distinguished practitioners in the field. And the panel that we were fortunate enough to assemble and that we are honored to host tonight will discuss some highlights of their diverse educational and practice paths, including the opportunities they've created and the challenges they've encountered along the way to their current situations. And they will also mention something about their visions for the future of the field, both prospects and potential obstacles. So let me introduce the panel. First, we have Dr. Santosh Rao, MD. He is the incoming president of the prestigious Society for Integrative Oncology, and he started and directs the new Integrative Oncology program at University Hospitals right here in Cleveland. Dr. Rao is going to talk about what it's like to establish an ambitious IO program at a major hospital system with an extensive existing integrated medicine network, and that's now known as Connor Whole Health, which I believe is now the largest integrated medicine program in the whole country. And he's going to talk about that and what it's like to navigate the system as he attempts to carve out the new program. Dr. Rao, thank you for being here. Then we have Dr. Kevin Brown, MD. He is a founding member of the Cutting Edge Integrative Oncology Working Group. He worked as the lead integrative oncology physician for Kaiser Permanente, Colorado, where he helped develop a multidisciplinary IO program of his own. But he has recently chosen to step away from the hospital setting and into the radically different world of private practice by opening a new solo IO clinic in Louisville, Colorado. And he's going to tell us something about what motivated that transition and his experience in making it. And thank you, Dr. Rao. And then we have Dr. Nalini Chilkov, OMD, L.Ac. She is founder of the American Institute of Integrative Oncology Research and Education and is the author of 32 Ways to Outsmart Cancer, which is a best-selling distillation of her Outsmart Cancer system. Over more than 35 years of practice, Dr. Chilkov has, among much else, become what I would call a kind of ambassador from the world of traditional Chinese medicine and other integrative perspectives to that of conventional oncology. And tonight we'll hear some highlights of her experience and something about her successful approach to bridging the divide between those two worlds. So Dr. Chilkov, thank you as well for joining the panel. And we did have on the schedule Dr. Lise Alschuler, ND and Fellow of the American Board of Naturopathic Oncology. Dr. Alschuler is having a little difficulty getting on right now for various reasons, and she may or may not be able to join us in the middle of the discussion. I hope she will be able to come on, but if not, we still have plenty to hear from the three panelists who are here. But you know what? I'm going to just read through her bio in case she comes on. You're going to know who she is. So she is a professor of clinical medicine at the University of Arizona, and associate director of the fellowship in integrative medicine at the university's famed Andrew Weil Center, and past president of both the American Association of Naturopathic Physicians and the Oncology Association of Naturopathic Physicians. She led the Naturopathic Medicine Department at Midwest Regional Medical Center, Cancer Treatment Centers of America, and she now maintains a private IO practice in Arizona. And Dr. Alschuler, if she speaks to us, will draw from her more than 3 decades of experience in both hospital and small group settings to describe highlights of her own distinctive path in practice, education, research, organizational service, and IO-IM development, but from the standpoint of an ND rather than an MD or OMD. So that is the spectrum that we have, that we had planned for the panel. And each panel member is going to speak for 15 to 20 minutes. And then we're going to have questions, a couple of questions maybe prompted by their presentation. And then we'll open it up to the panel for any kind of free exchange of thoughts and comments. And then finally, we'll bring in some questions from the audience. If you have any questions or comments, please enter them in the chat. Try to get to as many as possible. Just one little change is I was originally going to have all 3 or 4 of us, four of the panelists, go through their talks and then come back to the questions and the discussion and then questions from the audience. But I kind of like had thought better of that, because I think if we do it that way, we're going to run out of time and not have any time for questions from the audience. So I think after each panelist gives their presentation, we'll do a little bit of some questions and comments for each person. So that is the story. And Dr. Rao, you are up first. Please take it away.
Thank you. Thank you, Peter. And thank you all for joining. Can you see the screen here?
Yes.
All right. So let me just kind of give you a quick overview, 15 minutes. You know, I will focus a little bit on how I'm navigating things, but I'm going to start just by talking about my background and how I came to this point. As you can see here, I'm a medical oncologist. I specialize in GU malignancy. I'm a director of Integrative Oncology at university hospitals, and I'm the president-elect for the Society for Integrative Oncology. So let me go through my background a little bit. First and foremost was how I got into this space. I, like probably many of you, was inspired earlier in my life through yoga and meditation. I actually did a biophysics major. I thought I was going to figure out biofield therapies. And here we are 30 years later, still hasn't completely figured out, right? But you know, I have inspiration through meeting leaders in the field, but at that time, there was no clear path. And I don't feel like it was well respected. I felt like through my training in medical school and residency as well, I really couldn't share this with anyone. Those were my concerns at the time. Once I finished my training, I finally did the fellowship in integrative medicine. I got excited to learn everything. So I trained in Ayurveda and different healing techniques and you name it, right? And I found people who were like me. So I could talk about it. I expanded my skills, but I could not really find real job opportunities, or they were limited. And also, we didn't have this clear evidence-based practice. Then I did an oncology fellowship, and I finally got inspired and found my voice. And I said, this is what I'm going to do. And that I found very powerful. I started collaborating with folks and networking. My obstacles there was I didn't find people that could really help me practice, or at least they weren't in my locale. That's always a challenge. And again, finding a job that allowed me to grow both as an oncologist and an integrative oncologist. It's not easy when you're starting out, especially, to become good at both. Then I became leader of a program at Banner MD Anderson. It was grant funded, gave me great opportunities. I met some wonderful people there. But the obstacle was, how do you really practice this? And how do you apply it in the setting you're in? And what are your specific principles that you want to adhere to? Those are personal questions. Finally, trying to become a leader in this field and developing research. We talked about Society for Integrative Oncology, and happy to answer questions about that. But there's groups now like AIHM, Integrative Oncology Working Group, for example, where you can find like-minded people, developing clinical trials and training as a leader, and slowly gaining respect. You know, I do feel like I'm respected. At the same time, I still feel like I'm kind of seen as different. And the obstacle is, what is my focus, you know, and how to make myself successful, and how do I live a life of balance, which we all focus on as well. It's difficult when your, you know, hands are in so many different things. So I thought about that. What are my principles? And these are my principles: being collaborative and networking with a variety of people from different backgrounds and specialties, trying to focus on evidence-based care, but I'm very patient-centered. And so that means something different to different people. I will kind of lean towards being more patient-centered at times, developing multidisciplinary programs that enhance clinical care, bringing my vision to life, and really sharing my passion, and then trying to embody what I believe. So how does that look? Well, we have NCCN guidelines in oncology, and, you know, trying to follow these as best as I can for symptom management. You know, that evidence is growing. You know, there was a recent ASCO SIO guideline that was put out last September, and, you know, very conservative, but I think this is the kind of thing and the kind of thinking that I think will grow in the future. You know, is this prescriptive? I don't think so. And at the same time, it gives us some backing that we can use when it comes to insurance basis for these treatments, etc. It's a step in the right direction. I started considering at my institution, how does this look? Okay, and this is what I came up with. The patients in the center, you know, they may be at different stages, whether it's prevention, diagnosis, treatment, or survivorship. And this is just my concept of what modifies it, like, you know, health equity and access, etc. And I really had to think, where do we fit in? What are the gaps that we can fill in this particular setting? And this happens to be what we have and what we don't have. So we already had cardio-oncology and tobacco programs, supportive oncology, etc. The green areas are the places that I want to add, you know, integrative care. And it wasn't easy. It was like, what is our identity? So I feel like it's lifestyle, it's symptom management, and stress management. And then, of course, answering questions for anybody who has questions about how to collaborate and coordinate integrative care. So this is kind of my game plan, okay, I'm sharing with you. Basically, I want to touch patients at each you know, point in their journey. And, you know, the things that are consistent that everybody can use is stress management, as well as integrative oncology consults. For the survivors, you know, especially for the ones that are more lifestyle related, I'm creating a lifestyle program with shared medical care appointments. For those who might be survivors or in active treatment, we have a symptom management clinic I'll talk about in a second. We're transitioning that into our inpatient program. We have some inpatient integrative care, but we're trying to expand that. And then we really work collaboratively with the referrals on the left. So this is my kind of blueprint, and about half of it has been done in the first year. So I feel good about that. This symptom management clinic was kind of probably my best kind of action so far. And really what this was based on is, how can we use NCCN guideline-based care for symptoms? And you see the symptoms on the right, very common, you know, with cancer: pain, fatigue, neuropathy, etc. And what we do is, after a consult with integrative oncology, patients can come to the symptom management clinic. And the real novelty is that I oversee it and I bill for insurance. and the patients get acupuncture and massage, and we're going to expand this potentially to Reiki, even yoga. I might even add meditation. It's a great vehicle, and it's worked really well. I mean, and this is just a workaround, really. But I'm able to bill insurance, and so I see what patients are actually getting billed. But half of them don't have any copays, and they come and they get their acupuncture and massage, and I write a note. It does make me multitask. I see 30 patients in a day, but it's not that bad. And I think it works. This is scalable. I've already been asked to expand this to other days. If I hire more staff, then I could have them also help support this. And then we refer as needed. So I don't know if this will be something in the future, but until we get really good insurance coverage, I'm telling you that it's been 2.5 months, and I'm seeing how happy the patients are. They've overwhelmingly been very happy with this. We also just created something called Health Tracks, which is music with meditation, but it's really personalized. We have an amazing music therapy program, and so we use our studio, and they can create a track that's personalized to them, type of music, etc. And then they also have a personalized meditation. It can be a mantra, it can be guided imagery or mindfulness. And that's something that they can listen to when they're getting radiation or chemo. So just very practical ideas. And then our inpatient program I kind of touched on as well. A lot of it is similar to our symptom management program. Lastly, our lifestyle program. I really want to pattern this off the anti-cancer lifestyle program. I'm going to use it. And really, it's just a virtual program. This has not been developed yet. So what does the future hold for integrative oncology? I think international collaborations are important. There's a lot of work going on around the world. And much of our complementary therapies obviously come from other parts of the world. It's important that we partner with them, India, China, etc. And then how it's used and utilized in different parts of the world is interesting. I think we need to work towards precision, evidence-based care. I think, Dr. Chilkov can talk about this more in terms of diagnostic testing. But, I feel like as an oncologist, we depend so much on testing and more precision when it comes to what we're treating and how to approach an individual patient. I think we need to get a little bit more kind of savvy that way with integrative oncology. Partnerships with industry, we need money to do what we want to do. Obviously, insurance coverage, and then continue education earlier. I saw Christina Gowland is here, developing an integrative oncology fellowship. Others, obviously AIHM is involved in that space. I think that's really important because many of us didn't get good training in this until we were already done with our medical training. And then I think this kind of main issue also is affordability and equity. There's limited care and access in many communities, insurance coverage. And what I don't like, and why I'm trying to do what I'm doing, is I don't like to enhance the gap that already exists. The more evidence we get, we're proving that acupuncture, massage, yoga therapy, etc., are helpful. And some people don't have space for it, access, or it's really on the patient to pay for it. So I think we need to develop models of care that allow people to get access to this care that we are finding is so helpful. Lastly, we have our SIO conference coming up in September. If you're interested, please register. There's also virtual. It's going to be in Banff this year. It will be amazing. If you have any interest in the Society for Integrative Oncology, you can email me. I also have a podcast. It's called Integrative Oncology Talk. I started it, but now I have 2 co-hosts, Lee Leibel and oh God, I'm drawing a blank, but Judith as well. Sorry, Judith L.Ac. And, take a listen to it. And if you have any questions, I will stop there.
We had one question, how is this billed to insurance?
It's billed through me. So there's something called antecedent care, and so what I'm doing is I supervise the visit. I got this. Our Connor Whole Health was working on this anyways in other scenarios, But I got this idea also from our pain management group. I mean, so there are other practices that do these things regularly, whether it's using, the nurse practitioners or whatnot. Many of the pain doctors are touching base with the patient and overseeing the care, but they're not always in one place at the same time. And that's how they practice. And so I think we need to be a little savvy about that kind of stuff. So basically, I am supervising. I bill for time. I could bill for complexity, but I bill for time and basically say, I'm present basically, and I supervise. It is a meaningful visit actually, because I see these patients so often now. They get to know me, and we are really managing their symptoms, and it's collaborative. So how can acupuncture be billed unless the MD? Well, it's just billing for time. We happen to be doing acupuncture, but we're not billing for acupuncture. We're billing for my time, if that makes sense. So far, it's worked. I mean, if you guys have thoughts on this, let me know. But this is what we're doing in other aspects of our integrative oncology program. So somebody gets massage, we're not billing them for massage. We're billing them for my time and the fact that I'm overseeing a certain amount of time in clinic.
I'm going to answer a question, which was, is there going to be a recording available? And for this and for the previous month's talk by Dr. Gio, and the answer is yes. Actually, going forward, all of our events that are recorded are available on YouTube, the AIHM YouTube channel. So just go to www.youtube.com/AIHM Global. And then you'll see Gio's talk, and within probably a few days, this one as well. Okay.
There's a comment, the Cleveland Clinic in Toronto, I'm guessing it says, does offer acupuncture treatment. Billing can be through acupuncture. Yeah, so the problem, this is all temporary, I feel like. And I think that obviously we all need to advocate for insurance coverage. And I agree with this, is disempowerment, etc. At the same time, we need to be patient-centered. And I think of this as, for those people, there's a lot of financial toxicity to being diagnosed with cancer. And I'm telling you, I've found, in many places, I've been watching this, in many places where obviously people need to make a living. And so, these things can be expensive. And we focus a lot on nothing comes for free. And until you have the insurance coverage, so it's, what is this, 95% of the patients, is that in Canada? It must be. So in our state, it's very ad hoc. So that's where, Canada may be ahead of us on this. Obviously the Affordable Care Act pushed this a little bit further. We talked to Medicare and Medicaid, and they said, come back to us with more evidence in a couple years. I think that we just have to kind of roll with the punches. So I don't think this is like a forever kind of situation. And at the same time, my concept is to have multidisciplinary care. So I wouldn't look at it as disempowerment. I think that, hopefully I enhance what those interactions are. I mean, we talk about natural products. We talk about whether there's a different modality that might be helpful. We talk about, a lot of things. Do you accept internships from such complementary disciplines? No, not here, not at our place.
Okay, well, thank you very much, Dr. Rao. That was great. And we're going to circle back at the end. But now, Dr. Brown, if you would take the floor.
Okay, thanks, Peter, and thanks, Santosh. I will share my slides here. Okay, can everyone see my slides?
Yes.
Okay, great. Let's see, slideshow. Okay. Yeah, I'm trying to get it into the slideshow format here a little bit better, but sorry. Okay. Let's see. Is it showing as a slideshow, or are you seeing all the slides off to the side?
The slides off to the side.
Yeah, sorry. For some reason, I'm having trouble getting into the slideshow format, but I can do it this way if I need to. Play from the start. How about that? Okay. Okay. Well, this is going to populate here. So yeah, it's a pleasure for me to be here. Thanks for the invitation, Peter. And so I am going to be talking about my journey to becoming a private practice consultative integrative oncologist. And yeah, there it is. Okay. And so these are the maroon bells. So one of the prettiest spots in Colorado. I've lived almost all my life in Colorado and love it here. And so I came back here after my fellowship. So I finished my oncology and hematology fellowship in 2002 and decided, so the first job I took was at the public hospital in Denver, the county hospital, Denver Health. Just practicing as a general oncologist there, just trying to figure out, general oncology practice. And after practicing there for about 5 years, I decided to take a job at Kaiser Permanente in Lafayette, Colorado, which is just north of Denver and not too far from Boulder. And so I was presented with a really different patient population. Different than I was used to. And so a lot of patients from Boulder who were seeing naturopathic physicians or, taking supplements, doing integrative modalities. And I found it interesting. And, at that point, I did not see myself as an integrative oncologist. I didn't really know what integrative oncology was, but I found myself interested in these patients. And I really found myself enjoying just hearing their stories. I like hearing people tell their stories. I liked having them tell me about what they were doing. I liked hearing about everything they were doing and what their naturopath was recommending. And I started to learn a little bit about integrative modalities that way. And I guess I sort of gravitated toward integrative oncology from that standpoint. Let me try and get this toolbar out of the way here. So basically, that's the direction that I was taking. And I started to sort of develop. So the first niche I sort of developed was as the person in the practice who could listen to these patients tell their story, and that I was kind of interested in hearing what they were doing. And so I did have some patients start to gravitate toward me, patients who were interested in taking a more integrative approach. And just over time, I kind of became the integrative member of my group. And so there was a pulmonologist who had her office down the hall from mine, and she was a good friend of mine, and she was interested in integrative medicine. And she also ran an integrative support group for lung cancer patients. And so she talked me, encouraged me to go to an SIO meeting. So in 2013, I went to my first SIO meeting, and I was kind of blown away by it. I was really impressed by what was going on in integrative oncology, and I kind of started to move more in that direction. And eventually I decided to do the University of Arizona Fellowship, and I finished that in 2017. And so, and then by the time I got toward the end of that fellowship, I started asking myself, what can I really do with this? And I think, there were a lot of different directions I still could see, but I really felt like I wanted to take it to the next level somehow. And it was actually a couple of my partners who convinced me, who really encouraged me to start seeing one-on-one consults. And I wasn't sure if I could make it work within the Kaiser system initially, but I did get some support from my business manager. I think that was a really important thing to get that support, although I did not necessarily have a lot of support from the upper levels of administration. Let me see if I can advance this. Sorry. So basically, what I ended up doing, and sorry, I'm going to try and advance these slides here. But what I ended up doing was I got approval to see 2 integrative oncology consults per month. So I got approval to use 2 of my consult slots per month at Kaiser Permanente to see integrative consultations. And, the only conditions were that I had to make it work within my existing schedule. And I was not given extra time, I was not given extra resources, et cetera. And so, I embarked on that. And as you all know, I think when you do these integrative consults, they can be lengthy. And, a lot of my visits were 90+ minutes in length. And so that was one of the challenges. Also, I think we all try to give patients some sort of a summary of our recommendations. And I think that was something that, I had to do on my own. I had to come up with my own template for that. I had to come up with my own dot phrases, boilerplate, et cetera, and all the teaching materials. So I was doing a lot on my own. I was doing a lot on my own time outside of office hours. And that was, those were some of the challenges with that. But it was a very popular thing that I was doing. The consults were very popular, and we had a lot of demand for them. And pretty soon, by the next year, and this was into 2018, early 2019, we had greater than a 6-month wait list for these consults. And in addition to this, I had a lot of patients who were wanting to see me just as a second opinion, even beyond the one-on-one consultations. So my practice was filling up with more patients who really wanted an integrative approach. Boy, let me see how I can advance these slides. I'm really sorry about this. There we go. Okay. So Integrative Oncology Program at KP Colorado. So that started with the one-on-one consults. And then once the one-on-one consults became this popular, once I had the long waiting list, I decided I wanted to get the information to more people. And so I came up with this idea for a monthly class. And so we did this monthly integrative medicine and oncology class. And that was it started out as an in-person class, and then it switched to virtual when the pandemic hit. And that was also a successful program, because in nearly 3 years of doing this, we served over 200 patients. And it was a 3-hour, once-a-month program where we just went over a lot of basic material. And, it was not giving personalized recommendations, but it was going over a lot of basic stuff that people were curious about. So I was still doing the consults. I was doing this class. I was seeing second opinions from within Kaiser. And over time, this is what my practice became. And in a lot of ways, I really felt like I had found my dream job. I felt like, it was an amazing niche that I had created. So this is the team that this is the integrative medicine and cancer care team that I worked with. So the nurse and the social worker and the oncology dietitian, and we all worked together to put together that 3-hour class. But as it turned out over time, I think there were some elements that just made it unsustainable. So I did not really have organization funds allocated for the program, for training, for promotion, for support. There was no extra time given for these visits, which could be long. There was no time given for to develop all these extra materials, like I mentioned. And also, in addition to all this stuff, the desktop medicine time, so the emails and the answering phone calls all seem to increase, because a lot of these patients, I love that they're proactive. I love that they have their questions, but they do take, more time than the average patient. And sometimes they have more questions and require more follow-up. So I do love proactive patients, but I think my patient panel started to become difficult to manage, and my job became somewhat unsustainable, I would say. And it came down to time. A lot of it came down to time, in terms of how much time I wanted to spend with my patients, how little time I was given, and how much time I spent at home doing the work instead of being with my family, et cetera. So in the end, I tried to make it work at Kaiser. They supported me for, like I said, a few years, but in the end, they couldn't quite offer me what I needed. So I decided to leave and that was January of last year. And so I left, and I took last year off. I took time for myself. I took time to be with my family, kind of get to know my kids again, and take care of myself and find some balance. And I had a really, really amazing year. I think it was really important for me to do that. But I missed clinical practice. And so I decided, I knew I wanted to get back into clinical practice. So my vision was that I would put together a consultative private practice and get out of the business of managing crises as much. I mean, I think the crisis management part of oncology was just one part that was very draining for me. So I wanted to have patients, have their own primary oncologist and come to me just for consultative evaluation and recommendations. So that was my vision for the practice. And it took longer to put together than I anticipated, but finally we opened our doors in May of this year. And this is it. This is Spring Trail Integrative Oncology. It's in Louisville. And I am a solo practitioner, and I have one employee. So just my medical office manager and myself are in this office. I had considered hiring a nurse, but in the end decided against it, at least at this point. So it's really a small operation, and I really enjoy it. And let me see. So really, the things that I offer in this practice are, I offer records review and second opinions. So I'll give people opinions about their conventional care. I'll give integrative recommendations. I will, do some functional testing and lab work that may or may not be covered by their own insurance. I decided, so I don't offer IV therapies. There is some demand for that around here, especially, but I work closely. There's a naturopathic oncology office pretty close, and if patients are interested in those things and in IV therapies, we can easily refer them over there. We are currently mostly self-pay, out of pocket. So that's mainly the model. And we are accepting a limited number of Medicare patients. And so, I I wanted to keep my Medicare participating provider status so that I could continue to do some locum tenens work. And so that's currently kind of the compromise I've come up with. But we'll see how that works out. And if I can keep doing that long term, just because, Medicare reimburses much less than what I'm otherwise charging.
Kevin, I'm sorry, we have to move on a little bit.
Okay.
But thank you so much for what you said so far, but I actually want to bring up a couple of questions that were in the chat.
Okay, sure.
And comments. Wait, hold on a second. Well, you have a question from your colleague Manoj Reddy, who asks you what have you found to be the top 3 challenges? And actually, before you answer that, I was just going to ask you, it sounded like sustainability was like the big motivating factor for you to go from hospital, which was secure, but it was so demanding, to this, sort of unprotected world of solo practice. And I was going to ask you, did you have to gulp hard before you took that step? Or was it just like, no, this is what I'm going to do and we'll make it work? And then Manoj is asking me, what are the top? So I guess I'm asking you that as a way of, was that one of the challenges, is like, you had to like really think long and hard about whether to do this or no?
Yeah, I thought long and hard about whether to do it. I mean, it was scary, honestly. Working for a large, stable organization and making the decision to strike out on my own and be a solo practitioner. I think it's if nothing else from a financial standpoint, I think it's a risk. And so I had to think about it for a while. And I thought long and hard. And in the end, I just felt like I had no other choice, that I had to do it for myself. And I'm glad I did it. But it was definitely probably a decision that I came to over a year or two. And then in terms of challenges, I mean, the main benefits are autonomy. I can boil those down. But the challenges, I think, it's really a lot of the business stuff that I'm not trained, that most of us aren't trained for. Human resources, et cetera, marketing, no guaranteed salary or benefits, and having access to adequate capital. I think in the first several months, I think any sort of venture, needs to be adequately, funded to have adequate capital. And I think I do, but, and then establishing a support network and a referral network and just becoming part of the kind of the ecosystem around here of different practices.
I wanted to bring a comment up that I thought was really relevant, came up a little bit earlier. This person says, patient-centered care is great, but all the other practitioners deserve to eat and have a decent home too. Income equality remains a giant US problem. Agreed?
I'm sorry, can you say that again? I'm not sure I understood.
He said patient-centered care is great, but all the other practitioners deserve to eat and have a decent home too. And he's saying income inequality remains a giant US problem. That's
income inequality. Okay. So there's income inequality between different types of practitioners. Is that part of what?
Yeah, I think that's the gist of it.
Yeah, well, absolutely. I mean, I think a lot of people are going to hear an MD talking about taking a cut in income and not be crying probably, but I get that. But I think that non-MD integrative practitioners need to make more, and I think that is a real issue. And I think hopefully if we could come up with a system where reimbursement is more fair and reimburses for what's actually being done, counseling, talking to people about their symptoms, et cetera, no matter who's doing it, I think that type of approach should be reimbursed fairly. So I agree with that.
I think the gist of this comment is really, patient-centered care by definition takes a lot of time, as you were saying. So, can people survive on it and since so much of it is not covered by insurance,
Yeah,
there's a balance between, what do you need to do to survive and what do you need to do in terms of making it reasonably affordable for patients, right? So there's
absolutely. Absolutely. And that's what I think is one of the main challenges for the field moving forward. I think that, I think we can create this model, at least in private practice, we can create a model that is patient-centered and that delivers what patients need and can keep us financially afloat, but it gets to be expensive. That kind of a model, it does get to be expensive for a lot of patients, and a lot of people are priced out of the system and can't afford it. So I think, I really enjoyed hearing Santosh talk about the group visits and billing for, multiple people getting these procedures at the same time from an MD perspective. But so I think new models are needed. I think it's probably, group visits are maybe part of the answer. Changes to reimbursement policies down the road, hopefully, are part of the answer. But in the meantime, it's tough. It's tough to, when we're trying to give people a lot of our time, which is valuable. We've done training and we have to be able to bill for our time. To bill for a couple hours of our time is necessarily going to be kind of expensive.
Okay, thank you. We'll try to circle back again. And Dr. Chilkov, would you please take the floor?
Oops. Okay, let me get my slides up here. Somebody else is sharing. It says I can't start sharing.
Yeah, let me stop sharing. Sorry about that.
Okay. Okay, are you seeing my screen? No, not yet. Are you seeing my screen now?
Yes.
Okay, all right, here we go. I'll make good use of time, I promise. So I'm going to tell you my personal story and decisions I've made along the way. In a month, I'm going to be 70. So I started out when medicine wasn't so institutionalized and everybody just hung their shingle out and practiced solo, no matter what your licensure was. It was the era of private practice. And so that's where I started and that's where I've remained. And I'll also share with you why I decided not to participate in an oncology group. But the first thing is, I think, you have to love complexity, you have to love uncertainty, you have to have high risk tolerance to do all of this, because if you're going to do something that might not be agreed with or might be unpopular, you have to understand that that is part of the challenge and really stick to what you feel is best for your patient and prove a model. So that's what I have done, is I've wanted to prove a model. And so I'm licensed as an acupuncturist and doctor of Oriental medicine in the state of California, which makes me a primary care provider. And so I can write labs, I can order radiology, I can practice solo, I don't have to be under a medical doctor. But also, because I'm not a medical doctor, I've tried to figure out how I could practice and not get arrested. So my practice and my mission has really landed in an area where I feel there's a big gap. And that is because there's a shortage of oncologists. There are all these cancer patients being referred back to their primary care providers when they finish their HIT medicine part of care. And primary care providers, frontline clinicians don't have the skills and training to understand these patients. So I've sitting in the niche of how do we serve the health needs of cancer patients, whether they're actively in practice, in treatment, whether they're recovering or they're long-term survivors or they're living with cancer as a chronic illness. They all need a health model. So my mission is at the moment of diagnosis, everybody gets a disease team, the best experts and specialists you can find, and then they get a health team too. They get the best health experts, so they also have a plan for their health. And that means the health team is going to be with the patient long-term. And so that's really important because the health is a lifelong journey, right? It's a lifelong journey. So this is a question that one of my mentors asked me when I was new in practice. And she said, what do you know about healing that has nothing to do with your training? And the reason I mentioned this is because it got me out of my box of what my scope of practice and my role and whoever I thought I was supposed to be when I walked in with the patient. And it caused me to bring everything I know in my life into the room with the patient. So that meant that I could teach them meditation, or I could, if I had an actor in my office, I would ask them to play the part of a person who wasn't anxious about going into chemotherapy and try that on. And so I would use story as medicine. And so it just gave me permission to bring all my wisdom of experience of my whole life into the room with the patient, which transformed the way I practiced, but it also meant my life wasn't compartmentalized. I was the same person with the patient as that I was in every other part of my life. And so that was good for me also. And I stopped wearing a lab coat at that point too, because I didn't want a barrier between myself and my patient. And so that was, you have to think about what's good for you in your practice as well as for your patients so that you don't burn out. And so my core question is, what if every cancer patient has a plan for their health, not just a plan for their disease? And so I think it's important. I think we all agree that N of 1 treatment plans are the best. Try to give as much individualized care as possible. And Santosh mentioned using more biomarkers and lab assessments, which I do a lot of in my practice. I have a whole series of biomarkers I track every 3 months in all my patients to look at the cancer terrain, to look at the tumor microenvironment. And I'll just tell you a quick story. I started using cell-free tumor DNA with Signatera, and I have a breast cancer patient who's 80, and we've been following her, and I suggested that we start tracking her cell-free tumor DNA because she really didn't want to have a lot of treatment. And so I supported her in that, but we discovered a recurrence long before her oncology team would ever have discovered it. And so that caused her breast oncologist to start using this. And so sometimes when we use a practice, if we're early adopters, then we can teach the oncology team something that's useful. So I'm an early adopter. And so I had an oncologist I've been working with now for 35 years. And I started doing vitamin D on every single patient. She asked me why I was doing that. And I explained to her. Now she orders vitamin D on all her patients. So the whole thing I'm going to talk about today is relationships and collaboration, because that's how I grew my practice. And I just focus on relationships. So it's really important. But I think it's also important to have a framework so that you have a way to teach the patient your paradigm. And so you have a system that you can work inside of, so you're not reinventing it every time you do a treatment plan. And I also have to say, I would not be where I am if I didn't have a mentor and a community of clinicians to bounce my ideas and my struggles and my questions off of. I think it's really important, especially when I started out, there was no training. So I was lucky enough to be mentored by Dwight McKee, who was an extraordinary integrative oncologist, and he's retired now, he's almost 80. But I went over all my treatment plans with him all the time. And finally, he gave them back to me without any changes. And I said, okay, I know what I'm doing. So the question I often ask myself is, what's the oncology team not doing that I could do? What can I add? So what I want to do is look at what the oncology team has decided to do for the treatment plan for the patient and say, how do we make a more comprehensive approach? What are the holes in that? And so I know the oncologist isn't taking care of the microbiome, or isn't worried about the patient losing weight and losing muscle mass, or keeping their digestive tract intact so that they can have repletion of their nutrients. They're not tracking magnesium levels or vitamin D levels. So I try to see what's the oncologist not doing, what can I add that won't be in conflict with that. And so that's one thing. And so the core of my message is communication, relationships, collaboration. I call up oncologists. I send them notes. I say, this is what I'm doing with your patient. This is my rationale. This is why I'm doing it. So they begin to understand that I'm adding value, and what we're doing is working together in the best interest of the patient so we get the very best outcome. That patient can stay and finish their course of treatment because we're managing their adverse effects really well. We're keeping their weight up. We're keeping their digestive system in track. We're helping them have a sense of agency. So on my first visit with a patient, I only have two goals. One is to give them back a sense of agency and empowerment, because that's taken away in the conventional oncology environment, and patients get more anxious when they feel less control. And so I let them know that all their docs just work for them and they're the head of their team, and that they need a team. They're going to have many docs that serve them, and that there's some of them are going to be in the conventional oncology setting, some will be on their health team, but they're the head of the team. They get to decide, and they get to decide the timing. They have to have the right to be a well-educated patient and have their questions respectfully answered. And so that is my first goal, is that the patient feels like they get control over their body, their time, their decision-making. That's one of my goals on the first visit, and that they understand they need a team and who's going to support them and how. I also have a nutritionist that works in my practice, so that all the patient teaching that needs to be done about how to implement what I recommend and how to implement our Outsmart Cancer diet. A lot of these patients, as Kevin alluded to, they need a lot of hand-holding. So I make sure that I have patients who are highly engaged, but I also want them to have the support of somebody to answer all their questions, and I don't want it to be me. So I have my nutritionist do all of that with them, which frees up my time to do more of the analytic planning part for them. And I also think that language is very powerful. So what we say to our oncology colleagues, what we say to the patient and the family, I have language that I use so that I can build bridges and develop collaborative relationships and get buy-in from the patient, because I ask them to do really hard things. And so I need them to be all in. And so I say to my colleagues, my oncology colleagues, you're the health expert, you're the disease expert, I'm the health expert. And so I'm not going to step on your toes. I'm not going to mess up your treatment plan. I'm an expert in interactions. And so I'm going to support the health side. And that doesn't mean I'm not also doing things that influence tumor cells, but I want the oncologist to understand my intent is not to replace what they're doing. And I think that is a misunderstanding that a lot of conventional oncologists have when we come on board, is they think we want to take over treating the tumors, but that's not my job. It's not my training. And so I make that clear, and it has made space for collaboration and mutual respect and value. And I also talk really a lot with the patient about how to reframe what the cancer journey is, so that it becomes an opportunity for transformation and healing. And so I think we need to reframe that. Often with stage 3 and 4 patients, I say, you have cancer as a chronic illness. It's like diabetes or cardiovascular disease. We're going to monitor it and manage it. You're going to live with it with a good quality of life. And those kind of reframings for the oncologist, for the patient, I think are really important. And how we speak and how we language is really super important. And then I think about what's really possible. So my goal has been to prove this model, that it matters, that if patients have individualized care, and if they're educated patients and they can lobby for what they want to their oncologist, And so I educate them to say, go ask for this, and so ask them to do the cell-free tumor DNA, ask them to track your vitamin D levels, ask for an extra week. You're on a 14-day chemo cycle, you just can't do it. Ask them for another week and letting the patient know they're not going to die if they take an extra week between their infusions. And so patients then also have more collaboration with their oncology team in that way. It's a win-win for everyone, I think. But also, my goal for the patient is very different than the oncology team's goal. The oncology team is fascinated by the cancer and the tumor, but I am interested in long-term health and quality of life for my patient and restoring healthy function and supporting healthy function and getting them through their treatments and making sure that they live as long as possible before they have a recurrence, or having just a way to manage cancer as a chronic illness with a good quality of life. So that's, again, what's the oncologist not doing? What can I do? And so that's how I think about it. But you have to really understand that the oncologist has a different goal than I have or that you might have for your patient. So just to reiterate, I want the patient to have a sense of agency and empowerment. I want them to be educated. I want them to be able to advocate for themselves with their oncology team. And by doing so, I want their anxiety and overwhelm to decrease. So that has to happen on the first visit. They have to feel like, we got this and we're going to take control of it, and you get to make decisions about your own life and your own body and your own care. And then to sort of educate them about how to navigate through the oncology universe, and that reduces their anxiety as well. I think oftentimes there isn't a lot of patient teaching of what to expect when you go through chemo or radiotherapy, or what does it mean to have immunotherapy. So I feel my job is also to educate the patient so that they have more clarity about what's happening to them. And the partnership with the patient is super important, because that's how you get buy-in and that's how you get engagement. So I work hard on all those relationships and I stay in communication. So let me just tell you some other stories that are examples of why this is so important. So I had a patient, advanced colorectal cancer. He had a bowel obstruction. He was hospitalized. He was really end stage. And he knew he was dying and he didn't want to stay in the hospital. He wanted to go home and die at home. But with hospitalists, oftentimes the oncologist doesn't know what's really going on with the patient. And so, but I always know what's going on. So I called the oncologist and I said, this patient is well aware that he's in his dying process. And can you order a hospital bed to be delivered to his home? And he wants to go home. He wants to be there and with his family. Let's start hospice. And so the oncologist wasn't aware that that was the patient's wish. So it was my opportunity to make that happen for the patient. I had another patient. She was one of the first endometrial cancer patients to get Keytruda. She was diagnosed at stage 4 with significant burden of lung mets. And those women died historically. No matter how much treatment you gave them, they died. And so she had neoadjuvant chemotherapy. She had good response to that, but she came to me in the middle of it because she was losing so much weight because her digestive tract was so raw from the treatment that she just couldn't eat. So I asked the oncologist, give me a little bit of time and until the next infusion. And we really worked on healing the lining of her digestive tract, putting back some muscle mass on. She was able to complete her treatment and she had a significant reduction of tumor burden, but not 100%. So he's a researcher at UCLA. He gave her Keytruda and she had one of those amazing magical responses where she's been NED for the last 6 years. But she has a severe colitis come with the onset of the active immune stimulation from the drug. So we're going in circles with the oncologist. He wants to give her more steroids. I'm saying, no, I can't do that. And so we're going in circles. We're on this conference call, the three of us, patient, this wonderful oncologist, myself. And I finally said, Dr. Konechny, you don't have any treatment managing autoimmune disorders. So I have treatment in that. So can you just let me do this with the patient and get her off steroids and manage the autoimmune inflammation without steroids? And he goes, do whatever Nalini says. But that was because I had a long relationship with him, that we could have that conversation and he could feel comfortable saying that. And so we got the colitis under control with naturopathic medicine. And so she got off steroids slowly. She's NED 6 years now, and she still has a little bit of low grade colitis. And I'm imagining that's evidence that her immune system is still mobilized against her cancer in a small way. I'm hoping that's what it is and not just autoimmune colitis. So that's an example of why relationship matters. And so he and I've shared a lot of patients. And now he says that when he's done with what his toolbox is, he tells his patients, you should continue to see Nalini. You should not stop seeing her. I'm done with you, but you continue that so you stay well. And we have another stage 3 ovarian cancer patient. She watched her mom die of ovarian cancer. She watched her dad die of pancreatic cancer. 2 weeks later, after burying him, she was diagnosed with stage 3 ovarian cancer. And after she went through standard of care with my support, she actually had no evidence of disease at the time of her debulking surgery. And so her oncologist, this wonderful oncologist, wanted to put her on adjuvant chemotherapy plus Avastin, standard of care, right? And she didn't want to do it because she said, I don't have perceptible disease. I don't want to do it. And he really wanted her to do it, and she didn't, but she's a really highly compliant patient. And I said, let's try doing it with a naturopathic approach. And he said, okay. She is 5 years NED. And so, but you have to have compliant patients. I ask a lot of my patients, I ask them to do a lot and I insist they be compliant. And so that's part of proving the model. So sometimes it's lonely to practice this way. If you want to be a change maker, if you want to be a renegade, you have to realize sometimes it's lonely and you're just as a voice in the wilderness, but you have to stand your ground and feel what you're doing is right for your patient. And, you know, a lot of conventional docs will disagree, criticize, not want to work with you, not want to refer to you. Find the ones that will. So I've forged relationships with the docs that understand the value of what I'm doing and are willing to have a dialogue and share patients and really focus on relationships and outcomes. So I do not try to give oncologists studies for them to read to defend what I'm doing. Number one, they don't have time. They don't read them. And so in a short conversation, I can tell them what my rationale is. Sometimes I just make them short little memos, explain to them what I'm doing and my rationale. And so they just have some communication. But if I know I'm standing on solid ground clinically, then I just do what I think is right for my patient and in the best interest of my patient. And even if everybody else disagrees with me, and you have to follow your own compass and be congruent with yourself. And I don't practice in an institutional setting. I have no partners that I have to please or deal with. And I am not a medical doctor. It's not constrained in the same way that some of you are. But I still think it's important to focus on the relationships, focus on the outcomes, because outcomes speak for themselves. And my outcomes are good. And so if we all really do this and follow through and not feel constrained, demonstrate this model, that's what's given me leverage. And I have lots of oncologists that refer to me and want to work with me. So that's our goal, is to have a seat at the table and to have a voice. And so outcomes matter, relationships matter. That's my main message.
Wow, that was great. Thank you. You have a fan who says that you're a superstar.
I'm just a maniac, basically. I'm
Maniacs.
mission driven, that's what's true.
Also, there's a question from Paula asking, she says, I'm an integrative oncology nutritionist and would love to find a mentor. How do you recommend doing that? And integrative oncologists are so busy, she said.
Well, So because there's so few people really well trained to do all these things we want to do. And when I started out, there was no training. So I was lucky to have a mentor. But I started the American Institute of Integrative Oncology to give people access to this framework and access to me. If you want to have me give you feedback on your cases and have some mentorship, I have a platform for that. And then I think, you have to see if you want actually to be in your community. It's really hard to find an oncologist that has time or interest. Like if somebody asks me if they want to follow me around in my clinic, it's like, oh no, I don't have time for that. But if you want to have access to me, come to my mentorship group. So I think that you have to look for something like that, the new group, that the Integrative Oncology Working Group is a great group. Find colleagues that you can share your cases with and discuss with. The Naturopathic Oncology Association is a rich resource, both of great training and community. So, we can't survive without each other and without community, because it's a big learning curve for all of us. And we need to share our experience, our wins and our losses, and things we've tried and haven't tried. And you have to have a financial model also. You can't work for $10 an hour, and this is time intensive. So I charge a lot of money for my time. And that gives me the opportunity to have wealthy patients. I can prove the model, but it also gives me the opportunity to take patients at low cost, take a handful of patients that I don't charge very much money to, because I don't just want to have an elitist practice, but I have a lot of super wealthy patients that could do everything I think we should do. And that's how I prove the model. And so I think that once I share patients with an oncologist and show them the value of this, they're in. I don't have to give them a study. The patient's in front of them. That patient's doing better than their other patients. So I think that's really all we have to do, really, at the bottom line.
But we have about 10 minutes or so left. And what I'd like to do in that time is have a round. Well, first of all, if any of you folks would like to comment on what's been said so far, have anything to add, any questions of each other, whatever, please do so. But also I'd like to circle around to, I think everybody has spoken about their experience to date and things that, your current enterprises. I am interested to know what your perspectives are on the future of the field. Like, are you really hopeful? You see more and more happening. I mean, obviously, Santosh, you've got this great program going and it's being well funded, and more and more is happening. So I would think that there's optimism there. But if you could just comment about what you all think is coming down the pipe, for good or ill, or both.
I mean, I could.
Yeah.
Go ahead. Okay, fine. I think that, many of us are still looking at this where it's going from, this is something we were interested in and is really important and we want to expand, to now, how does this become standard of care? And those are two separate things, because then you start talking about, scalability and the issues that we deal with in oncology in general, that probably none of us want to really think about. We need to educate people so that, it's not just us, but it's, the breast surgeon, it's, whoever, the nurse practitioner, the acupuncturist, everybody has some touch point with the patient, because we can't see all of them. And then public policy as well. How do we have less patients to see in the future by having healthier people? We're still kind of in the same mode where, at least for me, I'm seeing people who are already diagnosed and stuff, and we have too many people. I also think we need more practitioners, and so this is what's happening now, where it's good to be busy and it's good to have people interested in this, and yet we're also, I think, vulnerable to getting burnout, or all the issues that come with, how you actually scale this. So those are my thoughts. And I think that there are a lot of people interested in this. There are more training programs. But I think that'll be the next challenge.
I always think it's good to go in baby steps because and pick steps are going to succeed so that we keep proving our model. So, I encourage, I think it's a team sport because cancer is complex and these patients have lots of needs. And so I want to do what I'm best at, and I don't want to do all the patient teaching. So that could be done by somebody else. Or, we could decide we're going to do a set of biomarkers on all patients and see if that matters. If we optimize everybody's vitamin D, if we make sure every single person gets their microbiome supported after they finish their chemo, does that make a difference long term? If we just do a study on astragalus and see if their neutrophils and their leukocytes are maintained, but I think if we just go in small steps and keep showing that what we do works, that's been my experience. Is once a straight conventional oncologist sees that the patient does better, they're happy to have someone they trust to refer to.
Like cumulative small effects having a large cumulative effect for the future.
Yeah, I would just say that I think the future is bright, mainly because patients want this. There's a huge demand, and I think it's growing all the time. And I think hospital administrators, healthcare administrators are realizing it. They're just trying to figure out how do they make it work within their own paradigm of moving people through and, short visits and all this. And I think so some paradigms have to change. The thinking needs to change somehow. But I do think there is overarching optimism because patients want this, and we're going to figure out ways to make it work better. We have to.
Do you all think that there's just more and more receptivity to this approach, not even in the general public among patients, because work has obviously gotten out to some degree compared to like 20 years ago or whatever? You see a momentum that way, I guess is what I'm asking.
I do. Yeah, I think there is momentum, and I think patients are finding more and more strength from patient groups and social media and at meetings and at society gatherings and at guidelines panels. You're seeing more patient advocates, and you're seeing a more patient-centered approach slowly take over. And I think it's still not where it needs to be, but I think that the patient-centered part of it is really what's absolutely critical for integrative oncology. And I think it's happening slowly.
Yeah, I think we're listening to patients. I don't know, Nalini, you can comment because you're a little older in terms of how it was before, but I feel like we're not only listening, but that it's being shown that we should be listening, and that having a personalized approach and a culturally sensitive approach, and letting somebody have some choice, all that kind of stuff is really, really important, and that's part of what's driving this. I also think that among our colleagues in the oncology field, there's enough evidence, but also maybe it's just a generational thing. I just feel like there's so much receptivity now, where I just didn't sense that 10, 15, 20 years ago. Whereas now it's an in thing. I don't sense a lot of, reservation like I used to.
Well, I think that a lot of change in medicine is driven by the consumer. And so like my generation, we changed the way childbirth was done, not because doctors wanted to do it, because all the women wanted it. And so I think if patients have a voice, they ask us to be better clinicians and give them better care. I see two things going on. Certainly the general society, I think, feels more empowered to have a voice. But I also am very disturbed by the fact that medicine has become so institutionalized. In the era of lots of solo practitioners, there was lots of freedom. The doctor could decide how much time to spend with the patient and what they were going to do with them, and didn't have to follow standard of care because nobody was reading their electronic medical record and slapping their hand and that they didn't do it. So, and on the way that young doctors are being trained to do short visits and to just look at the standard of care and follow it instead of think about their patient. So I think I worry about that. And so I think that the type of person that is motivated to go into medicine is often an independent thinker, and it just gets socialized out of them in their training. And so we have to find those docs that still think for themselves, I think, and don't, it's about risk tolerance. If you're going to do something new and innovative, you have to have high risk tolerance. You have to be willing to be challenged and not have thin skin. That's what I think. And so, there's enough of us that can do it, I think.
I'd just like to add this little capstone to the evening. My own observation, I've been observing the scene for over 40 years, myself, long before I became a practitioner. And I've just seen this evolution from decade to decade, from open hostility and, everything was quackery, wasn't conventional medicine, to sort of like a grudging coexistence 10 or 15 years later, to some degree of cooperation. And then, in the recent years, this integrated model has developed. And I would even take it one step further and say, maybe 20 years from now or 50 years from now, there'll be not integrated medicine, but unitary medicine, where everybody is like really on the same page and understands that this should be done in these circumstances and that should be done in those circumstances. Not rigidly, but it's just like there's one body working together. That's just kind of my vision. But I don't know if we'll reach that last stage, but I see all the other evolutionary steps that have taken place. So I think it's very positive, but I guess maybe it's going a little slower than some of us would like.
But I think also all of us are, kind of probably like-minded in this sense, where we're really focused on not just treating disease, but wellness, promoting wellness. Mm-hmm. And I think that healthcare has to change. I mean, it still is a business that in many cases kind of almost capitalizes on people being ill. Mm-hmm. And, all of us are talking about, not only individual patients, but how do we change the mindset towards promoting wellness? And that goes very far. That goes into the food we eat and the environment and all these other things. And we're trying to survive in a system that is not perfect for us. We don't do surgery, we don't give chemo, we don't, in some cases, some of us do radiation, but those are the big money makers. And those are for people who are really sick, right? And we're trying to keep people away from that in a sense and keep them healthy. And so that has to be incentivized, right? And I just think that that's kind of I think the US population really wants that. And they recognize that, I'd rather obviously not get another cancer or whatever it is, right? So I think that's the movement, I think, is that, we just have to continue to preach because we're on the same side as most of the population. That's just my take.
You know what else? Patrick Hanaway and Mark Hyman proved that their functional medicine clinic at Cleveland Clinic saved the insurance company money. And so we need to use that model to demonstrate that also because, the insurance companies own the doctor and own the patient. So we have to figure a way to convince them this is going to be cost effective for them.
I mean, 25 years ago, it could have been shown that using acupuncture for knee pain or back pain, osteoarthritis, whatever, that could have saved a whole lot. That's a whole lot cheaper to reimburse than an osteopathic surgery. So but insurance companies weren't particularly open to that, even though it was in their best interest, but it was just not enough of the zeitgeist at that time for them to accept it.
Depends who you're talking to. There are oncologists that get on the phone with with the insurance company and lobby for the not standard of care protocol that they think is best for their patient and give the adjuster the rationale. And that's what I used to do. If I'd had a migraine patient and they couldn't get their insurance company to cover it, I'd call up and say, this can be so much less expensive than all these failed expensive prescription drugs. Give me 3 months, cover it, and then let's talk. And so it requires that effort, I think, to get a yes out of somebody.
Okay, does anybody have any final words before we break up the meeting for tonight? If anybody in the audience is interested in receiving our monthly newsletter to be apprised of events such as this that we have from month to month, I've got my email and Amy's email in the chat up there. So you can take that down, let us know you'd like to be added, and we will do that. Okay, well, if nothing else, thank you all so much for taking your precious time out of your busy schedules to come and speak for us here. I think this has been a really great evening, and I appreciate it very much.
Thank you.
Thank you.
Okay, everybody, good night. Thank you again.